Hi, this is Amy. Today we are going to be talking about pulse volume recording and segmental pressures. I am first going to go through each exam, and then I will go back and answer these questions that I haven't gotten to simply by talking about the exams. So first we're going to talk about the segmental systolic limb pressures. For this, you want to have the patient laying supine for at least 5 to 10 minutes before you do it to get as close to a basal reading as possible. There are two different types. There's a 3-cuff method and a 4-cuff method. The 3-cuff method uses 3 pressure cuffs. The 4-cuff method uses 4 pressure cuffs. For the 3-cuff method, whenever you put the cuffs on, you use 17 on the upper thigh and 2 10 to 12s on the calf, one just under the knee and one at the ankle. For the 4-cuff, you use two 12 centimeters on the upper thigh, and then you use 2 10 to 12s on the calf, one below the knee, one at the ankle. You also put a 10 to 12 on your patient's arms to get the brachial pressures as well. So first you would obtain your brachial pressures. To do that, you would either manually pump up the cuff with your hand, or you would use a machine. At Bockwell, we do have a machine, but we don't have a pen probe, so we actually have to use the regular ultrasound machine and image the artery as we pump it up and pump it down, and then just listen for whenever the pressure comes back. So when doing the arms, a pressure differential of 20 millimeters of mercury or greater suggests subclavian artery stenosis on the lower side. You also do not take a pressure with a shunt or dialysis graft. To obtain the blood pressures in the legs, you would put the pen probe on the PTA or the DPA, and you want to make sure that if you use one on one side, that's the same artery you use on the other side. You would first inflate the lowest first, because you don't want to create a falsely lower waveform than would naturally be. So you would start with the ankle, then you would go up to the calf, and then you'd go up to the thigh, and whether you're doing a 3 or 4 cuff, if there's 2 on the thigh or 1. So that is the segmental pressures. You can also, for segmental pressures, you can also do the toes as well. It depends on your facility. Our facility personally does not, but for that you would just, at the end, inflate a 6 to 8 millimeter that is on the big toe, and it basically the same thing. Whenever it cuts off and whenever it comes back. So for ABIs, which is for TBIs, I'm sorry, anything greater than 0.75 is normal, and anything under 0.66 is abnormal. And to get that, you toe brachial index, you are dividing the toe pressure by the brachial pressure, which is what you get at the beginning in the arms, and that's where you get your values, your 0.75 or your 0.66. So for resting ABIs or segmental pressures, anything greater than 1.35 is probable calcified arteries, because the arteries aren't compressing. Anything 0.9 to 1.35 is normal. Anything less than 0.9 is abnormal. Less than 0.8 is probable claudication. Less than 0.5 is multi-level disease or long segment occlusion, and less than 0.3 is ischemic rest pain or severe disease. For the 3-cuff technique, All segmental pressures, including the thigh pressure, should be equally or slightly greater than the brachial pressure. A 30 milligrams of mercury or greater drop in pressure generally is considered positive for hemodynamically significant stenosis, which is greater than 60% in diameter in the segment. A normal thigh pressure usually rules out significant aortoiliac disease. For the forecuff technique, there is something called the high thigh cuff artifact. The high thigh pressure should be at least 20 millimeters mercury above the brachial pressure due to this. That would be the highest one, so you have one up closer to your hip and then one right above the knee. It would be the one up closer to your hip that has that high thigh pressure artifact. So an abnormal for a forecuff segmental pressure would be a thigh pressure that is less than arm pressure is abnormal. A pressure gradient of 30 millimeters of mercury or more between the high thigh and the low thigh is suggestive of superficial femoral artery disease. Studies have shown that a normal high thigh pressure rules out significant aortoiliac disease. And low thigh, calf, and ankle pressures are interpreted as in the three cuff technique, so it's interpreted the same way. So to summarize, if the upper thigh pressure is normal, then there's no significant inflow disease. If the upper thigh pressures are abnormal, you must rely on waveforms to determine whether there is an inflow or femoral artery disease. That is the segmental pressures and what is abnormal. So a pulse volume recording is where you leave the patient supine with the heel of the foot placed on a pillow or pad and apply appropriate size blood pressure cuffs and snugly to the thigh, calf, and ankle, and if indicated, the metatarsal, which would be the great toe. These are the same cuffs that are used in segmental pressures. You instruct the patient to be still. The waveforms are then recorded for each limb. Pulse waveform analysis is a quantitative assessment of pulse contour and amplitude. Because the calf amplitude is slightly higher than the thighs and ankles, some labels will perform PVRs at the calf level first, and this is to gain a waveform size of the scale. This scale is will be retained for the thigh and ankle sites. So I'm just going to show you this image really quick here for the PVRs. This one is normal. This one is mild disease, moderate disease, severe disease. So the PVR mostly relies on the waveforms and not listening for when your pressures come back. Okay, I'm just going to look at these questions real quick and see what else I need to answer here. I believe I went through it all, the difference between a PVR and a segmental pressure. The segmental pressures are not using the waveforms, the PVRs are using the waveforms. The 3 to 4 cuff method is 3 cuffs, 1 on the thigh, 2 on the lower calf, 4 cuffs, 2 on the thigh, 2 on the calf. And so we'll go over the hoses really quick. Most places that I have been have had color-coded hoses. There are certain ones that go to the brachials, the upper calf, the lower calf, the toes. Each one has its own, but these are indicated on the machine that you are using. So if you have a black hose and it says black is for brachial, those are the ones that you will put on the arm, the cuffs that are on the arms. The probe is usually a pen probe. It's just an acoustic probe where it doesn't do any imaging. You just hear the pressures. We don't do that at our site. because we don't have one. I believe that's it, but thank you, I guess.